the presentation is going to be about. So we can start with the track one. So Tara and Steve, you can start the preview session. That'd be great.
So Amika, we're doing a little preview of what's
Yeah,
to
just
come.
1 minute. Yeah.
Oh, sure. Okay. I'm Adrienne Navarro, and I'm here with Karin Typor. Karin, yeah. And we are talking about an exploratory qualitative study I was able to conduct in England under the Mental Capacity Act. From that research, we've actually been able to apply that to some work with the NASW and actually to some training that's going on through Karin and her practice. So we'll be talking a bit about why capacity is such an important domain when we work with older, vulnerable adults, and really a roadmap on how to become competent.
Great. So it's in Adrienne is in a track two. So let's start with track two presenters then. Thank you, Adrienne. So the next presenter in track two is Annalie. Annalie, are you here?
Hi, good morning, everyone. My name is Annalie, and I will be talking a little bit about the barriers that victims of elder abuse encountered and how professionals within the system handle the barriers and how they recommend to make change within the system to help older adults who have been victimized.
Thank you.
It was as a research assistant for Professor Carson, I looked over about 25 interviews and pulled information from there.
Okay, great. Sounds great. Thank you, Annalie. Mia?
Hello. So thank you. I'll be looking at different key strategies and themes that legal actors and prosecutors use to guide older adult victims through the prosecution process of elderly abuse cases. Just understanding that they're in very vulnerable situations and how to avoid re-traumatization during that process.
Thank you, Mia. Emerson?
Good morning, everyone. My name is Emerson. I'm a project coordinator at UCSF. And then today I'll be talking about a project that we're doing that is creating a training for caregivers of LGBTQ plus long-term survivors of HIV. We had done focus groups, and we'll be talking about how we conducted those focus groups and how those focus groups were really key in centering LGBTQ plus experiences in creating something that is trauma-informed, gender-affirming, and HIV sensitive. Thanks.
Thank you, Emerson. Georgette?
Good morning, everyone. My name is Georgette, and so I made a directed project, and it's called Adverse Childhood Experiences and Their Impacts on Older Adults. And what that entails is I made a pamphlet, an intake form. I want to make a workshop, and so all of that will fill in the gaps and how we admit older adults into boarding cares, assisted living, and stuff like that, so they can have a better quality of life.
Fantastic. Thank you, Georgette. Then Pauline and Elizabeth.
Good morning. I'm Pauline DeLang Martinez. I'm from UC Davis, our Family Caregiving Institute in the School of Nursing, and I'll be co-presenting with Elizabeth Bogomil, who consulted with the Inland Coalition on Aging and is based at UC Riverside. And we'll share about a 5-year project of engaging 3 rural regions across California to understand what are the challenges and policy recommendations around housing insecurity, long-term services and supports, and access to healthcare.
Okay, great. So these are the 6 presenters in track 2. So if you're interested in this set of presentations, and then you're going to be staying in this room, the track 2 session. So moving on to the track 1. So that's another breakout room hosting 6 presenters. So let's start with Tara and Steve.
Yes, good morning. Thank you for having us here. My name is Tara Faragian. I'm the Community Resources Supervisor for the City of Los Alamitos. And my colleague here, Steve, see, we will be discussing LoSal Link, which is a citywide transportation, but it is no cost for older adults 50 or older within the city limits of Los Alamitos.
Thank you, Tara. Natasha?
Hi, good morning. My name is Natasha Alexa Garcia, and I'm currently in my last semester at Cal State Long Beach, and I'm going to be presenting my directed project, which is called Navigating North. It's a brain health and vitality program for older adults. And this program is informed by the evidence from the finger and US pointer studies. It's essentially a dementia risk reduction program through lifestyle intervention. And I developed a facilitator guidebook and a 12-module curriculum and materials to go with the program. And I'll be presenting that. Thank you.
Thank you, Natasha. Crystal?
Morning, all. I am Crystal Neal, and this morning I want to present on pastoral care and adaptive grief, being able to process with families in bereavement, helping to support our pastors and using narrative therapy.
Great. Thank you, Crystal. Mila and then Rachel.
Good morning. My name is Mila Lillian. I am the supervisor for our tech program, and I'm here with Rachel Holben, who is the manager of our Insights program. And we'll be talking about a class that we developed that's a 3-series course that kind of marries our mental health program along with our technology program to help older adults and caregivers who are 55 and older to prevent social isolation out in the community.
Thank you. Next is Celia.
Hi, good morning, everyone. I'm apologizing for my video, which is off right now. I had to switch devices and my video is not operating correctly on this device. So yeah, thank you for the opportunity to present. I am Celia Lastic, founder of TUI Care Strategies, LLC. It's an organization focused on culturally responsive caregiver education and workforce development in aging services. And today, I'm sharing findings from my dissertation on how collaboration influences caregiver training program planning and implementation in a nonprofit aging services context. This presentation highlights leadership, stakeholder alignment, and operational challenges, and also offers practical implications for strengthening caregiver training and workforce readiness. Thank you.
Thank you, Celia. Deanna?
Hi, everyone. I'm Diana. I'm a graduate student researcher at UCSF. And this talk will be about, it's a scoping review that we're working on, looking at the experiences of caregivers before, before, during, or after a disaster, and how they kind of manage safeguarding their care recipients.
Thank you, Deanna. So these are the 6 presenters in track 1. So if you're interested in listening to those, presenters, and then you're going to be going to the breakout room 1, which we are going to create shortly. Right. And at the bottom, you see best of showcase voting and evaluation. What it is that we're just going to do a fun polling asking for your favorite, among the 6 you listen to. So you're going to have a poll, Zoom polling towards the end of the event. And if whoever gets the most votes is going to have a little gift from us. So it's non-scientific. We're just asking you, that what was your favorite, and then that's how we're going to wrap up this session. So just think about, as you listen to those fabulous presenters, and then you're going to have to make a hard decision about which one, but we're asking you to pick one for that best of showcase voting at the end. Right. Donna, I can turn it over back to you.
Okay. Just to answer your question, Deanna, yes, we are recording these. And so we will, as soon as they get whatever they need to do in the recording thing, we're going to send it over to the CCGG web mistress, and she will be posting the presentations on the CCGG website. So I would say probably by next week, I don't know what her time looks like, but Alex, next weekish, will they be accessible if we get them to you?
Yeah, I can make that happen.
Awesome, awesome, awesome. And just one more thing. So you can bounce back and forth. I don't know that you can personally, so I don't know how that works. Once you place yourself in a room, I guess if you're in track one and you want to go back to track two, you just come back to the main room. And then if you're in track two and you want to go to track one and you can't, let me know and I can place you. So it's not like you have to pick one track and stay there. If you want to see stuff from both, you can do that also as well. So any questions about the process of the day?
And then we're going to come
So
back to this. We're going to come
Yeah.
back to this main room, right? After the session is over.
Yeah, after the
Okay.
session and you vote, come back to the main room, but that way both rooms can hear who the winner was, and then we can network if people want to kind of make connection, or if you had more specific questions that you wanted to dig into about a presentation. So yeah, it is so lovely to see so many faces. We used to have an annual CCGG conference, and then COVID threw a wrench into that. And so we started this research showcase as a way for us to kind of share some knowledge and share the work that people have been doing. And it's just seems like it's getting better and better every year. So thank you all for being here. And so now I am going to create the second room and out room. And y'all get to choose what you want to do. So those okay. So they're out there. Are you guys seeing access to be able to join track one if you want in the breakout room? Not yet.
So that's called room one, right? Is that?
Yeah.
Okay. Yeah. Let me
Are
just.
you seeing that, Amico?
Yes. I just renamed it to track one.
Oh, okay. Thank you.
So I'm gonna go. So for the presenters and also the people who are interested in the track one session, please go ahead and select the breakout room named track one. And I'll go there too. So I'll see you soon, Donna.
Okay. Is anybody seeing that besides Amico? No. Okay.
I think I have to click on the three dots that say more on the bottom, and then I could select join breakout room. That's how.
Okay, yeah, because I'm not assigning you, so you'll have to do that. So yeah, click on. Okay. We'll give a few minutes for that, a minute or so. Does anybody want to go into the breakout room and is not able to do that? Okay, so it looks like we've kind of leveled out here. Okay.
This is Alia. I went to get into a breakout room, but I don't see the options under more.
Okay. Do you have just a breakout room tab on the bottom or not?
I don't. I'm on my phone right now because my previous meeting
Oh,
ran late, but I'll be at a computer shortly. And maybe I can look on the
okay.
computer. But
Let me see if I could do that, if I can move, yeah. Somebody was saying earlier, it just seems like every time I log into Zoom, like functions have changed.
right.
And where I used to go for things.
They make little tweaks. Yeah.
Yeah. So let me see what I can do, Alia. Alia. Huh. All right, I'm open for feedback if anybody knows how I can assign somebody to a breakout room.
If you're the host, you may be able to right click on their name in the participants list and assign it to breakout room. At least that Zoom used to allow you to do that at one time. Don't know if it's still there.
And
I
I
get
just
the
popped
option
in,
of
I popped in from the breakout room to find Diana, who's going to be, or Diana, who's going to be presenting. Did she make it over into the breakout room? Okay, I don't see her here.
Yeah, I don't see her here either. But I could put her in a waiting room, but I don't think I want to put her into a waiting room. That is so weird that, yeah, I'm not seeing where that option is, Alia. Um, Let me try one more thing. Ah, here it is. Okay. Boom. Just Alia, I assigned you to the breakout room. You may need to accept it, but you should be signed up there. You just need to join. Okay. Here we go, guys. Sorry about that. So we are going to start off. I'm excited. We just never know who's going to propose, make proposals for us. But I was excited. We've got this little bit of a mini track on vulnerable adults and elder abuse. And so I'm just so excited that we're going to get a lot of information about that. So I'm going to kick it over to you, Adrian, Karin. You could take it away and get us started. I'm going to be monitoring the chat. So if you guys have questions, you can put them in the chat or unmute yourself and ask them.
Fantastic. Thank you. I would like to just start with introductions and then I'll share my slides. We just have a couple of slides to share with you today. I'm Adrian Navarro. I'm a longtime social worker in healthcare. I went on to get a PhD in gerontology, and I found after a long career a real need to look into decision-making capacity. So I'll be talking about that today. And through my work, I was able to meet this fantastic colleague, and I'm going to let Karin introduce herself. She's probably the one person not from California today. So, Karin?
Interloper. Yeah, I'm Karin Typhor. I'm up in Seattle. My private practice is Aging Care Consultation Services, and I was thrilled to meet Adria through doing a lot more learning myself about decision-making capacity and how we assess that, which I kind of got into a lot of complicated elder abuse cases while working for our area crisis team. And that as being able to assess someone's capacity is something that there's a huge need for providers who are trained and educated and capable at doing those assessments. So I'm thrilled that Adria and I are collaborating on doing this work.
Thank you. So I want to start by just saying the focus today is on decision-making capacity assessments, and specifically for the population of vulnerable adults. You'll hear these needs come up, obviously, in working with other populations, but our focus has been with older adults. And I am focused initially here really on how I wanted to explore social work being involved in doing these assessments and how could we become competent to do that. There's one other collaborator, here listed is Epi Leishman, who is from York, England, and I was so pleased to meet her. This is a busy slide, so I'm going to just interpret it. After a 2022 visit to England, to York University, I was able to put together a qualitative study to explore the fact that qualified social workers were doing this work. So the study that I went through the IRB and got approved was to explore how qualified social workers practice and provide decision-making capacity assessments in England as guided by their Mental Capacity Act of 2005. I went ahead and set up a protocol for doing interviews with these different social workers, and these were structured interviews. And then we basically, I analyzed that with Epi Leishman, Dr. Leishman, and we used a method called saliency analysis. So if I make this a little larger, does it look larger to you? Oh, good. Okay, because I know this is a busy slide. This was presented in 2023 to the Gerontological Society of America. And because of the work that's kind of come from it, I wanted to present it briefly to you today and then be able to introduce you to Karen, who's been such a wonderful collaborator for us. So after looking at these semi-structured interviews, we were able to kind of come up with some themes that came from that, of course. The sample was just 9 British social workers. They represented diverse social work roles and employers. I met with some folks that were doing consultations for hospitals. There were some inpatient hospice workers, 2 of them that I interviewed, as well as in England, they have a social care, the authority of the social care. And there was a consultant that was educating their social care workers, as well as somebody that was doing that work in the field. So the findings, I like how GSA asked you to do these kind of focusing in on the content in the middle. And that's what I really think is important today is kind of talking about what does the Mental Capacity Act suggest that we do? And so there's 5 principles that are written into this piece of policy over in England, Wales. And what's so interesting too is, Karen and I have looked at the research, and there's been a lot of kind of throwing basically back to Griezel and Applebaum's work that really helped define what are we talking about when we talk about decision-making capacity, taking it from being a diagnosis-specific kind of domain and then really looking at it as a function. So it's interesting. I'm going to be doing a lifelong learning class today on brain health for some older adults, so I'll be popping off later. But all this kind of comes together. I think in the work that both Karen and I have done, we've found that this becomes such a critical part of a care plan. So the 5 principles I think are really important to emphasize. We start out by presuming that everyone has capacity. And I think that when we begin to question that, it would be a decision-specific kind of situation, something critical that needs to be decided. And that's when we would basically come to the table to think about whether or not a consultation is needed to assess capacity. The second principle, I heard the word optimize when I talked to the social workers in England, but this idea to provide whatever supports are needed to make that decision that we're focusing on. And so it would talk about, being sure that information was provided and being sure that if they had any barriers such as language or maybe a disability where they needed things in a different format, that was provided so that they had every opportunity to understand the information. The third is the right to have unwise decisions. And so that's where a lot of us know there's folks that we serve, those in practice here, that make decisions that may feel eccentric or different than what we would advise. And yet if they have capacity for that decision, we need to honor that. We need to step back and honor their decision. The 4th principle is to act in their best interests. And that's again where concepts like if there's a situation where we don't think they have capacity, then we begin to look at what would they have wanted if they could make a decision at this point, what's important to them, and what's been their pattern, for example, in spending money and things like that. Then the fifth one is very common to all of us when we think about things like placement, but the idea of to provide the least restrictive option. And so making sure that of all the opportunities that basically we give them the option for the least restrictive. So the themes that came out, I really wanted to understand, since there was this structure already in place by policy, what were the practices that they had, what was important to them in practice, what values really were the foundation from which the work springs from, and then how did they get trained up? How did they get competent to do this? The values are important, and you see those are a bit bolded here, that you can see those better, which is to be person-centered. And I know that we've all been experiencing, that comes into our legislation from the Affordable Care Act, to be person-centered, to look at integrity in all that we do, to honor self-determination, respect, using, again, the least restrictive options, to use your support network of the person involved whenever possible, and to think about when we do this assessment, the time of day. We want to be able to assess people when they're at their best. When it comes to training, I'm going to have Karin talk a bit about that. Just before I do that, I wanted to just mention the functional test that is written into the Mental Capacity Act. Again, comes from this Applebaum and Griso work that was done in the early late 1980s, and you saw some literature from the early 1990s. But really this idea, when we talk about what is decision-making capacity, it gets broken down into these 4 concepts, and these are written into the Mental Capacity Act over there. So I got very curious about that. And I think the timing, that period of time was part of that. The first is, does the person understand this specific decision, all the issues that are involved in this decision? Can they retain the information? Let me make this a little bit bigger if you can see. Yeah. Can they retain that information long enough to be able to make that decision? Can they weigh up? And this is a little bit different language that's used in England than we use here in the States, but can they weigh up or reason? And look at the information. So pros and cons, for example, and then can they actually communicate that decision and basically pick a choice that's based on pros and cons. So this is sort of what they call there the functional test. And just to wrap up this work, I'll just say that there was a template that was in the publications that were there in England. So they're on the poster. Let me just go back real quick. I was trying to move it for you, but I'll move us instead. There we go. Farmer did some great work where he talked about what actually goes into the assessment, breaking it down. And that's where I became very curious. If social workers are to become competent, we really need to know what's included in this kind of an assessment. And so there's some references that are specific to England and the practices there. But I think taking this research, I wanted to bridge it back to practice in the US. And so coming back, thinking about where does this apply? And I just wanted to indicate, in healthcare, we always generally get consent for any procedure, for example. But part of that consent is, can the person do that? Do they have the ability to make that decision? And so it's kind of sort of glossed over a lot of times. And again, we assume capacity unless proven otherwise. Independent living decisions. Some of us work out in the field, in the community, like I have for years. And so we want to know if people, for example, when they say, I don't want to work with adult protective services, I go away, or I don't want to hire help in the home, do they have the capacity to make that decision? And then certainly as today goes on, we're going to be talking about elder mistreatment, such as financial exploitation and undue influence. And so do they have the capacity in those situations? So you'll see some highlighted references here. A lot of the foundation work that Karin and I turned to has come from a handbook back goes back a bit now to 2008, which was the American Bar Association and the American Psychological Association's assessment of capacity in older adults. They had a work group that basically came up with a handbook. They also have one for attorneys and judges. And so this work actually broke this down. And one of the folks on the work group was Jennifer Moy. And in 2020, she came out with a book, and I have it with me here. Karin and I were just yeah, we were just teasing. It's always kind of next to us when we're working, but she's written a very helpful book on that. So anyway, I want to turn it over to Karin because it's interesting as we think about this work, and I know Ben is on today as well. I wanted to get the information out so people could present cases and get information, consultation on the work that they're doing, because regardless of us not being in the statute as social workers or mental health providers, our mental health licensed counselors, physicians and psychologists are actually written into the California statute to do these. And so now that there is an updated as of January 1st, 2025, the Declaration of Capacity has a spot now where information can be uploaded. And so that's where I think those of us that are not physicians or psychologists can actually support this kind of work by adding in our assessments through that portal that's available to add us into the report. So training and consultation, I got a lot of interesting feedback from the folks in England. And actually, when I met Karin through a very renowned prosecutor in the States here, she turns to Karin Typor for consultations to the court. And so I found that what she does very much mirrors and matches what the social workers were saying in England. So Karin, I'm going to let you talk a little bit, and then if you'd like, I can put the roadmap up that we came up with when you're ready.
That would be great to put that up. Yeah, like I said, I had worked with a crisis team that we got some complicated elder abuse cases, and those are, typically very messy, as you can imagine. So I have the personal history of my grandparents were exploited out of their life savings in an elder abuse situation. So I had kind of a personal passion for those cases as well. So I kind of became the point person on the team, willing to take those cases, and really was a lot of self-taught. There aren't a lot of training programs out there specifying or, really focusing on capacity and how to assess it. So Paige Ulrey, the prosecutor here in Seattle and King County, was phenomenal in coaching me and mentoring me about how to do these assessments and because they really need to be used in court. And I've gone to court to testify, and having my assessments really scrutinized by the court process it was a huge learning curve. So because I was somewhat the only person in the Seattle King County area doing these cases, really wanted to train up some other professionals in, getting their skills and knowledge of what's involved and what the whole process is like in doing these cases from the beginning all the way through to possibly testifying in court. And in the process of putting together a couple of trainings, and I'd done 3 part-day trainings back in 2024, and that was about the time that I got connected to Adria. And Adria, with your mentorship, we talked about really outlining kind of a roadmap. And I love that term because we're not saying you absolutely have to take this exact road, but this is kind of the direction to go in. And that first base area is kind of the clinical core competencies. So having that background in geriatrics, having clinical licensure, because if it comes to testifying in court, having that clinical licensure is huge for credibility. And a lot of education, training, practical experience in tests, cognitive tests and other assessment tools, being familiar with supports, whether that's visual or hearing supports, other kind of ways to optimize the person's ability to participate in that assessment, and being able to document for a good report as well. Then that middle section, that capacity specific knowledge, is really the piece that's missing for a lot of clinicians, that we just don't get training on that in our graduate programs. Even doctors and in medical education don't get a lot of training on that as well. And in the medical field, they're mostly focused on medical decision making. They're not focused on how to evaluate someone's financial decision making or the capacity for independent living, for example. So having some coursework around the relevant legal standards, as well as the different types of capacity. I love Sabatino's question. We never say capacity, we say capacity for what? What is the specific decision at hand? And being able to assess the decision-making process for those different types of decisions. There are a lot of different tools out there that can be very helpful to walk someone through the process of how they make their decision in order to assess those 4 steps that Adria talked about: the understanding and retaining the information, being able to appreciate whether it applies to their situation, being able to reason and judge the pros and cons, and then to make that ultimate choice. And then there's also a kind of another step of the functional piece of, can they carry out that choice? Can they do the things that they need to do to be able to, for example, to live independently or to adjust to changes that come up in their situation? And then I believe too, the third part of this is really a practical learning process. And this has evolved that in the beginning, I said, people really need to shadow an experienced assessor and then have that assessor shadow them. The difficulty there is not everybody has someone in their local area that is doing this work. So we kind of have pivoted to the coach mentor model. And I did this with a couple of colleagues where we've kind of pre-gamed, talked the situation through ahead of time, what the referral information was, what kinds of tools and strategies they're going to use in their visit, and then kind of debrief afterwards to talk through the visit, their observations, their working approach to the case, et cetera, and then reviewing the documentation to see how they wrote up their findings and recommendations, and then having consultation. Adria last year did a wonderful consultation group that focused on decision-making capacity, and I've kind of taken up the mantle with her permission to do that going forward. And that group is also, it's open to anyone to do case consultation around capacity-specific questions, and then with the last part of it kind of reserved for people who are doing this work and have taken some trainings to really talk about the professional development side of things. So that's the roadmap that we've come up with, and it's certainly something that anyone could approach on themselves. I'll put in the chat, there is a training program that we have through Elder Education Institute at Sound Generations here in Seattle that is really focused on that middle column of the capacity specific knowledge. And it's actually kicking off next week, May 6th, and we still have room. So if you're able to join us, we'd welcome you. Thanks so much.
Thank you. And I think I put the link down. Did I? Yeah, right here. This one here. I wonder if I can grab that and I can put it in. Oh, maybe you better do it. So I'm going to go ahead and stop sharing. Is there any questions for us? I know time is going to be important to watch. We have like 3 minutes, I think.
Actually, we're at time.
We're at time. Okay, wonderful.
Yeah. So if you have any questions, put them in the chat. And Adria and Karen, I'm sure you'll monitor the chat for things that come up. That was lovely, though. The salient, I mean, there's lots of information here, but the salient kind of thing for me just to hear articulated, we're not just looking at capacity. Capacity isn't a yes or no blanket answer. And that kind of sticks with me. Capacity for what? So thank you. Thank you. Okay, it looks like there's a question there for you, but we're gonna move on as a group. Next, we're gonna have Annalie Bowers from CSU Sacramento talk about systemic barriers in elder abuse response, insights from interdisciplinary professionals and implications for holistic reform. So Annalie, take it away.
Hi, good morning. Thank you very much. So we'll just get back to the beginning of my slides here. There we go.
Perfect.
So good morning, everyone. Thank you, Donna. Thank you guys for being here. My name is Annalie Bowers. I'm a gerontology student at Sac State. And this semester I have been working with Professor Katrin Koss as her research assistant, during which I analyzed 25 interviews with professionals across different fields involved in elder abuse response systems. And many systemic barriers were identified. And I'm going to highlight the top three. Additionally, participants highlighted important changes that they think would enhance the system response to elder abuse. So the question is, what systemic barriers prevent effective responses to elder abuse, and how can they be addressed? So one of the biggest barriers is that agencies work in silos. Social services, law enforcement, APS, and legal professionals are often working separately rather than together. And as a result, the victims are left trying to piece everything together for themselves and navigating these multiple systems that don't communicate well with each other. This lack of coordination slows response times and makes it harder to address the full scope of the victim's needs. Additionally, didn't change it. Additionally, another major barrier is that systems offer very limited options. In most cases, victims are often left to choose between either criminal charges or restraining orders. But these options don't address the underlying issues like mental health or substance abuse use, and they do not reflect the complexities of family relationships. Many victims don't want incarcerations, they just want the behavior to stop. One advocate put it, it's really rigid, and I wish I had 4 or 5 more options. At the same time, housing is a major constraint. Victims and their abusers often live together and are often financially dependent on each other. And so without affordable housing, separation isn't a viable option, and victims feel trapped. There's currently no emergency placement for an older abuse victim or any foster homes for an older abuse victim. Some even choose to stay and try to manage the situation themselves, where one participant shared a story of a victim who plans to put a lock on their bedroom door and just stay in their bedroom. A third major barrier is time. Elder abuse cases move slowly through the system, often taking months or even years to resolve. During that time, victims are still in contact with the person causing harm, and these delays create opportunities for manipulation, where the perpetrator can pressure the victim to withdraw the case or change their story. So the longer the process takes, the longer the case breaks down before it reaches a resolution. So some of the solutions discussed were across the board, most professionals repeatedly pointed out a need for a one-stop shop. So creating a one-stop system with APS, law enforcement, advocates, and all these other professionals working together would improve communication and keep the focus on victims' safety. It would create a single entry point where coordination will begin from the beginning. Also, a part of that model will be a trained forensic interviewer where they would collect the victim account once and share it across with the professionals, so that way the victim won't have to repeat themselves and be re-traumatized. Housing will also be addressed, where without stable, affordable housing, victims cannot separate from their abuser without risk of suffering homelessness, sorry. So a long-term housing solution will be essential. Expanding the range option is also essential. Treatment-based alternative should be widely available. This includes counseling, family mediation, restorative justice, diversion to mental health or substance abuse treatment, and community-based programs alongside or instead of criminal prosecution. Like I said before, many victims, they just want the behavior to stop, not necessarily for their family member to be incarcerated. And finally, the system needs to move faster. Establishing timelines and creating specialized elder abuse courts can reduce and delay limited opportunities for manipulation. And so together, it's believed that these changes in the system from a fragmented and rigid to a more coordinated and flexible will create easier transition, reduce re-traumatization, and be more victim-centered. Thank you so much.
All right, nice job, Annalie. Questions? We do have some time here. If folks have questions or want to enter into some kind of discussion, I did see Karen. I think a few of your responses were to questions, but I saw our area multidisciplinary team has been hugely helpful in linking those silos Annalie described, especially in regards to complex family situations. Yeah. Any other questions or thoughts or?
Hi, Annalie. It's Catherine. Can I go ahead, Donna? Is that okay? Can I ask you a question?
Yes.
Great job. Really good job.
Thank you.
Maybe I missed it, but could you talk a little bit about the impact on the victim in terms of like what it's like to, you talked about having to navigate, but like what is it like for the victim to have to interact with all these different professionals and service providers and feeling like maybe they're, not being listened to or heard because they're being asked the same questions over and over? Maybe you talked about it. I might have missed it.
It can be re-traumatizing for them, having to explain themselves over and over, first to APS and then to the police officer and then to the lawyer, especially because there's no interprofessional or inter-office communication. So once the report goes to APS and APS passes it on to the police, APS doesn't know what happens when it hits the police, when the police officers get involved. And then likewise, when the police officers take it over to the prosecution, there's basically no follow-up on the case. And there was even a situation where one prosecutor had started a case and the case took so long that that prosecutor had transitioned out and moved to a different county. And that prosecutor reported that he didn't know what happened with that case when he moved and a different prosecutor took over that case. So that victim had to constantly be giving accounts of what happened, not only to the initial prosecutor, but also having to repeat herself or himself again to the new prosecutor. So it's very re-traumatizing for that person.
Yeah, great job summarizing the key lessons too.
Annalie, so my question is, you've got a great framework here, right? And I know that it's probably being applied differently in different counties, different states. And how do you see kind of systems that are ready to kind of move toward this more of a kind of collaborative approach versus maybe what we might call coordinated, right? What do you see as like, and I'm thinking more quote unquote the system. So looking at law enforcement and APS and the judicial system that are kind of all involved in this, and obviously social services with housing, mental health, blah, blah, blah.
I do believe
what do you think the barriers are to doing that?
I wouldn't know what the barriers are to doing it. Honestly, I feel like this is just my opinion and not according to the research or anything, but I feel like time and the lack of communication with each other And because it's, how would I say this? They do have, everyone wants the same thing to happen. Everyone wants the systems to move fast. And, but it's like, no one knows what's happening with each other. So it reminded me of an interview that I read where a prosecutor came in fresh, never done an elder abuse case before, and saw the miscommunications and the gaps and the barriers. And what that person did was basically kind of create their own one-stop shop where he personally went out to the police department and spoke to the detective and then went to the lawyer who was doing the cases before and made them connect with each other. And also the social worker got involved. So it kind of he created like this ring, so to speak. And then he also discovered that a lot of people where he was working didn't know how to identify elder abuse. And so he kind of had to educate them on elder abuse as well. So it's like it's a multifaceted thing where it's not just about the barriers, it's also about identifying elder abuse and knowing how to report, who to report to, and the next steps of because if the professionals don't know how to identify it and how to navigate it, they can't help the victims. So everyone wants to help the victims, it's just that no one knows how to. And then funding might be another issue because creating a one-stop shop, so to speak, having everything in one building might take a lot of funding. I don't know. I haven't done the research on the policies and funding and budget issues that would create, but that could also be a factor. I hope I answered your question.
You did. Thank you. Thank you. It's just such a multi-layered thing.
Exactly. Yes.
Yeah. Any other thoughts, questions for Annalee? You could throw them in the chat. Thank you, Annalee. Wonderful job.
Thank you. You're welcome.
All right. So next up, we have another Sac State student. Woohoo! Mia Harden. And she is going to be discussing ensuring that they are heard, supporting older victims through elder abuse prosecution. Take it away, Mia.
Hello, thank you for having me, and I'm gonna start sharing my slide. Alrighty, it's visible, I assume. Okay. Hello, my name is Mia Harden. I'm a student at Sacramento State University working under Dr. Catherine Koss. My research looks at how professionals support older adults during elderly abuse prosecution cases. This is important because we have to understand that these individuals are often in very vulnerable situations and very overwhelming situations due to the legal process, and we want to reduce re-traumatization and making this process as easy as we can for these victims. I'll be focusing on three key themes that emerge from interviews with professionals that work closely with these victims. So my transcripts and data was the same as Annalise, so she went right before me. I coded the data looking for patterns and repeated themes of how these professionals were supporting their victims throughout their prosecution cases. Okay. So the first major theme that emerged was legal actors and professionals establishing a rapport with the victims. One of the strategies was ensuring multiple in-person visits. I shared a quote from participant 10, an attorney. She states that she likes to meet with them more than once and going to a place where they're comfortable, especially like their home. Another strategy was ensuring that you're connecting with the victim beyond the case. There was also another participant, they described that when they would go to their victim's home for their first visit and getting to meet with them, they would look at photos that they had displayed in their home and different art pieces that they had in their home, and they would try to connect with the victim about these pieces. One, to get the victim comfortable with them and kind of to show that they are wanting to understand the victim beyond the case. Two other strategies were non-judgmental and active listening. Participant 7, also quoted in the slide, stated, taking the time to listen and being compassionate. All of these strategies are really important as they allow the victim to feel safe with the prosecutor, as they're going to be sharing such vulnerable and personal details with them throughout the prosecution process. So we want them to be comfortable as they can and having that rapport build. In the transcripts, there was also a story shared from a prosecutor that when they realized when they didn't put so much time and effort into forming that foundation with the victim, that they witnessed a total breakdown throughout the prosecution process of the victim, as in it was a bit more difficult communicating with them, and they noticed the difference between when they put the time in of building that rapport and when they didn't. And that just shows that rapport doesn't just help the prosecution process for the victim and for the prosecutor, but that is truly essential for the process. The next strategy, the next strategy that I found was having a victim advocate. The role of a victim advocate is to reduce the burdens that the victim faces throughout the prosecution process. One big umbrella strategy of having a victim advocate was providing empathetic support. For example, participant 17, they shared, also in the slide, they shared a story of having their victim advocate sit with their victim when they were testifying. This provided a reassuring role to the victim, and it also provided comfort during this really stressful time and stressful moment of them being in this situation. Other strategies were service connections, such as providing different services of food or housing or safety within the system to them, as we understand how difficult it can be to get certain services and programs just already, and then especially added onto the load of going through prosecution. Also, victim advocates can help navigate the participation that a victim can have within their prosecution. One story shared was that a victim advocate was able to be the voice of a victim by reading a written piece that the victim wrote in court instead of having the victim share their story verbally. This was one mode to give the victim autonomy and also was a way to reduce a burden, perhaps, of publicly speaking for the victim. This is important, having a victim advocate, as prosecutors don't get to play the same empathetic support role for victims, and that can be extremely neglected for victims. And also, it's important to note that not every victim receives a victim advocate, and understanding what a great support role they are, it can really show that the victims are at a higher risk of re-traumatization and feeling unsupported. The third theme that emerged from the transcripts was honest and transparent communication. One of the strategies from this was timing and delivery of information, making sure that it's adequate to the victim's understanding, the victim's education. Professionals emphasize spacing out information delivery so that it doesn't become overwhelming to the victim. Also making sure that you're providing that information in a understanding way for the victim. We all know that the legal process can be very difficult and confusing, and for someone that's not used to that, that can be even more overwhelming. Another strategy was describing the possible or likely outcomes of the prosecution in advance to the victim. This can reduce fears. This can also set the victim up for realistic expectations. It also reduces feelings of uncertainty that they're already gonna have throughout the case, but understanding what a likely outcome may be can reduce that if they are thinking of worser outcomes. Another strategy that was shared from the interviews was making sure that you are providing information about your role to the victim and being very honest and open to the victim about that. Prosecutors, they're working for the state, they're working for the public, and this is important when the victim may have a different understanding of what that relationship may be. They may feel that they were being misled if the outcome isn't what they exactly wanted out of the prosecution. So having that understanding that the prosecutor is working for the state and not just for the victim in that role. Overall, all of these strategies highlight a balance between addressing individual victim needs and working within the constraints of the legal system. Limited resources and institutional goals can make it difficult to provide consistent and personalized support to the victims. These victims, they all have different backgrounds, they have different forms of abuse, and they have different barriers in their life. So providing personalized support would be the best option, but it's a very rigid system, so that unfortunately doesn't always happen. But with this research, it shows that even within those constraints, human connection, advocacy, and clear communication can make a significant difference in the victim's experience throughout prosecution. Thank you. And if there's any questions.
All right. Nice work, Mia. Questions, thoughts?
I'll go again. Great job.
Okay.
This is Catherine. Sorry, if that's okay. Great job, Mia. What did you take it from this yourself in terms of your learning and about research, or about, what was surprising to you that you found about the process or about the data?
What was the most surprising was that I wanted to be about making sure everything was very thorough and not, since it was a qualitative study, making sure that I took people's words and information exactly for what it was, working with this different format of transcripts and interviews. I didn't want to shorten someone's words and shorten the message of the things that they shared. I wanted to keep them as authentic as possible, especially during coding. And I feel that that was a little bit hard because they're just sharing such important information. It's like, oh, I want to keep the substance. I want to keep all of it, but that can be a little not as effective.
You did a great job. Thank you.
Mia, just a question, kind of a practice that in the narratives that you reviewed where there was a victim advocate, did they discuss where that victim advocate came from? Was it from, I know county have victim witnesses program, things like that. But what was where did they come from?
Most of the ones that I read came from the county or from the state. Some are more for private attorneys. That I read, they had victim advocates that worked with them, and so that was also a method of having them. But I think what also shocked me was just that some people didn't have them, and I think it's completely unfair. But every system in every county and every different case is going to have different modes of support that they can provide. Hopefully I answered your question. Okay, thank you.
Any other thoughts, feedback, questions for Mia? All right. Well, you can use the chat if you have any lingering thoughts. So nice work, Mia. Yay. Okay. So we're a couple minutes early, but I think that's okay. We're going to move on to Emerson. And please, if I'm not saying your name correctly, I'm so sorry. Is it Shang? Shang. He is going to be discussing with us centering LGBTQ aging experiences in creating a trauma-informed, gender-affirming, HIV-sensitive caregiver training. Excited to hear this. So Emerson, take it away.
Fantastic. Let me start by sharing my slides. Okay, perfect. All right, good morning, everyone. Again, my name is Emerson. I'm a project coordinator, and I work under Jarman Ye at UCSF. And today, like Donna said, I will be presenting on creating a community-informed training that is being developed for caregivers of LGBTQ long-term survivors of HIV, and what we learned as we were gathering data via the focus groups. I'll first talk about the gaps in care and then a little bit more background on the project itself before moving on to how we conducted the focus groups and what we found in the data. The caregiving workforce lacks culturally sensitive, trauma-informed, and gender-affirming training to help LGBTQ plus adults aging with HIV live safely at home and in community. And these gaps disproportionately affect transgender and gender non-conforming older adults whose intersecting identities shape complex healthcare needs. When they need personal care assistance, often they encounter a caregiving workforce that is underprepared. They might understand HIV care, but maybe stumble over proper pronoun usage, or perhaps some do have experience in gender affirming care, but lack expertise or medical knowledge in managing HIV medication. What this all suggests is that there's a need for a training to provide respectful and affirming care, particularly to those managing the complexities of HIV. This project's goal then is to address these critical gaps in care by developing the first comprehensive training program specifically designed for caregivers of LGBTQ plus longtime survivors of HIV that can be replicable, scalable, and hopefully be implemented nationwide. This project is done in collaboration with Unlock, who has a long history of empowering older adults through quality care management and tailoring programming. And in 2021, they created a adult day program known as Club 75, which was created specifically for LGBTQ seniors and older adults living with HIV. In terms of informing the training curriculum, we conducted 6 community-led focus groups, which will be the focus of my presentation today. But we are also currently conducting key informant interview with caregivers and a caregiver needs assessment. And so in October and November of last year, 6 focus groups were conducted with LGBTQ plus older adults. They were facilitated by a trusted community leader and activist, Miss Billy Cooper, who is very well known in San Francisco. And we relied a lot on Miss Billy Cooper's networks as well as Unlock's partnerships with the Shanti Project, SF AIDS Foundation, and Open House to recruit for the focus groups. There were a total of 36 participants, ages from 48 to 82. 31% identified as transgender and gender nonconforming. 53% were people of color, and 61% were currently receiving caregiving services. These sessions were audio recorded and transcribed, and we conducted thematic analysis to identify key training needs to inform the curriculum. And because Unlock is taking the lead in developing the actual training curriculum, we asked them what was the best way to deliver our findings. And they said that stories and vignettes were the best because they found it to have the most impact and it centers the lived experiences. And in our report back to Unlock, we identified 9 priority training topics, which then we supported with quotes and vignettes. Today, I'll be talking about 5 of the 9. I'll be talking about caregiver training and preparation, respect, dignity, and cultural competency, the unique challenges of aging with HIV, client-centered care, and support for caregivers. One of the first things we learned is that long-term survivors of HIV often feel like people don't understand the history of HIV and AIDS, and that caregivers may not understand that long-term survivors represent the first generation to age with HIV, and that they lived through the AIDS crisis and carry that trauma, stigma, and loss while also navigating uncharted territory in aging. And this participant describes it as a war and that they're now phoenixes rising from the fire. This historical context is essential in providing compassionate and informed care. And to provide the context, we even had participants suggest that part of the training should include a portion where caregivers get to ask them questions in order to get a feeling of who they are. We also learned about the unique challenges of aging with HIV. Here is a quote from a trans veteran, and she tells us about her story with HIV, HIV-related medications, and the comorbidities that have come with her HIV care, including neuropathy, diabetes, and cancer. The main training point here is that caregivers need to understand that HIV management is just one part of complex health needs as they're figuring out aging as well. Next, we have a trans woman sharing about an experience in a healthcare setting where she corrected someone for using this wrong pronouns 4 times. By the end, she says, quote, "I just don't want her in my room anymore because I'm about to throw down." Correct pronoun use is not optional. It is fundamental in providing dignified care, and that misgendering, even unintentionally, creates barriers to trust and care. And this is especially critical in vulnerable situations like caregiving. When a caregiver automatically uses correct pronouns, regardless on how a client looks, it creates safety and trust. And the same participant later goes on to say, quote, "When I know that you're in my corner, then I can be more open about what's going on with me. If you're not with me, you're against me. How am I supposed to open up about what's really going on with me?" We also often found that transgender and gender nonconforming participants didn't end up providing a lot of feedback on a caregiver's work around their homes because the caregivers didn't even make it past the first hurdle, which was the respect. And can you imagine how hard it must be to allow someone like that to take care of you intimately, whether that's bathing you or just moving around through your home? This quote, "I had a caregiver who wanted to bring rosaries and pray over me. I'm grateful for the thought, but it's not your place to bring religious things into someone's house if you haven't been asked, even though it's well intended." We also had another participant share a story where a caregiver was uncomfortable with pornographic art on their wall and they removed it from the wall. Caregivers must leave their personal preferences, judgments, and agendas at the door. And what is important is to respect the client's living space, belongings, lifestyle, and autonomy. And that what matters here is the client's preferences, values, and their choices. My last quote here is from Brian's. Brian is a pseudonym, of course. Is a quote from Brian's husband and caregiver, talking about what it's like to give care as they've both gotten older with their with physical and memory issues. Brian has been positive since 1992. I'm the sole caregiver. He has many physical issues and serious memory issues. So I've been responsible for everything, keeping up the house, giving him his medication, seeing that he has his daily exercises, shopping, meal prep. 4.5 months ago, he got serious foot infection. He cannot walk at all. It complicates everything in life. It's extremely time consuming. It's very stressful. I'm really feeling it at this point. Caregivers need care too, in that we know burnout is real and can be dangerous. And so caregivers need support groups, respite care, and permission to care for themselves. In these focus groups, we were also reminded that San Francisco has a really rich history of community-led care, and that the Shanti Project used to have trainings and support groups for volunteer caregivers. Um, we learned that caregivers have the right to set boundaries, take breaks, prioritize their own health, and that the training should emphasize that sustainable caregiving requires self-care and not self-sacrifice. And so, in conclusion, the focus groups that we conducted offered really critical insights into experiences, challenges, and the needs of caregivers and clients of the LGBTQ community living with HIV. The participants shared really personal stories, highlighted systemic gaps, and proposed actionable recommendations to enhance our caregiver training and any support services that Unlock might offer. And I want to end with this quote from our focus group facilitator, Miss Billy Cooper. "We are the experts. They can have all the degrees, but our lived experiences far outweigh all of that." Thank you.
Wow, that was fantastic. Thoughts, questions, feedback? Emerson, one of the things that kind of really came up for me is when you hit that really we're looking at kind of the first generation of AIDS survivors, right, that are now older adults. And I don't know, I just hadn't really kind of thought about that before in terms of like, wow, how the world has changed, and in many ways, and in many ways not. So yeah, that just that brought it up to me, because looking at that historical, context is so important in this person-centeredness, because
Totally.
if I was a 20-year-old social worker coming in and maybe I hadn't lived through and seen how horrific things were when AIDS, HIV arc started, you may not have that sense of holy moly, what a journey, what these folks have been through. So thank you for kind of highlighting that.
Yeah, you're very welcome. I also want to point out that, you may not have thought of it, and the survivors also did not think of it. They did not think they were going to live this long. And a lot of them said, because we didn't think we were going to live this long, we did not do financial planning for ourselves. And so the future is also very unstable and unclear. Lorinda.
Yeah, sorry, I don't have my video on. It's not a good day. But I am wondering, I'm curious about whether through the work you have seen challenges that are kind of the reverse. So there's typically a very diverse set of gender nonconforming and that sort of thing groups in the healthcare world, in the residential settings, and are you witnessing people in the residences or work that are there receiving their care having displaying prejudice, that's animosity, that sort of thing? Or is that kind of no longer an issue? It was for me when I worked in Arizona.
No, it is definitely an issue. Another big part of sort of caregiving is that a lot of transgender and gender nonconforming individuals did not couldn't even get past getting a caregiver because they were already they felt so stigmatized, and they had a wall up because they felt like people were already going to misgender them. People were going to come in with preconceived notions of who they are. And a lot of them also had trust issues around like safety, being robbed. And so a lot of them haven't even thought about caregiving because these these first barriers haven't even been discussed or been crossed.
So what I'm specifically talking about are people who are what's the right word? Gender conforming as residents,
Oh, okay.
rejecting or because that same generation that lived through that were not impacted by AIDS but witnessed it also have a lot of inherent or implicit bias.
Yeah.
Yeah. And so how is that playing out right now?
You're asking about like so like cis participants, like gay cis men or like lesbian
Yeah.
cis women, whether they've been experiencing prejudice still?
If they're the carer, are
Oh,
they
if they're the
experiencing?
carers. Right now, I'm not sure. We are in the middle of doing key informant interviews with caregivers. And we're also doing a caregiver needs assessment with 200 caregivers. So hopefully that'll let us know what their backgrounds are and how they're experiencing all of that.
Okay, great. That's what I was looking for. Thanks.
Wow. Other questions? It looks like Bill put a comment. I'm amazed San Francisco is lagging behind on cultural humility for LGBTQ plus population. There are many programs out there that address this issue. Additionally, there are LGBTQ plus older adults who have lived through the AIDS crisis and did not persons with HIV. There are separate mental health issues with this cohort. Yeah. And it just, in something that's prominent in all four presentations that we've had so far is the whole person-centeredness, right? Meeting somebody where they're at, getting to know them, building that relationship. Yeah. When I know you're in my corner, I can open up. Yeah. And just the audacity of taking somebody's pictures down. Oh my goodness.
Yeah.
Okay, well, thank you so much, Emerson.
Thank you.
If you have more comments or questions, you can certainly put them in the chat, but we will move along. Next presentation from Georgette Chobieri. I'm probably not saying your name correctly either, from CSU Long Beach. Assessing the effects of childhood trauma in older adulthood. So Georgette, take it away.
All right. Technical difficulties here. All right.
That's okay. You're good.
Okay. You
There
guys
you
can
are.
see it? Okay.
Yep.
Good morning, everyone. My name is Georgette Chobieri, and I just graduated from Cal State Long Beach with my master's in gerontology, and I will be talking about ACEs. And today I will share why this topic is important, where the gaps are, and how my directed project, a toolkit that includes an intake form, a pamphlet, and a workshop will address these gaps. ACEs is an acronym for Adverse Childhood Events. These events are traumatic experiences that children experience before the age of 18. ACEs are often placed in several categories: abuse, neglect, and household dysfunction. These experiences have lifelong implications for people that are linked to higher likelihood of developing chronic illness, cognitive decline, and dying younger. As you see in this pyramid developed by Dr. Robert Anda, ACEs leads to disruptive neural development, which leads children to adopt risky health behaviors that persist into adulthood, leading to disease, disability, social problems, and all of these factors in premature death as compared to the general population. This project is personal to me as a former foster youth and an older adult who was diagnosed with several chronic diseases, including cancer. I want to create a better future for older adults. ACEs impact a person's personal and physical, mental, and social and financial health. They create chronic inflammation in the body, which is a leading indicator for developing diabetes, cancer, heart disease, and more. But those experiencing ACEs in childhood have a higher likelihood of developing these chronic diseases than the general population. They have also been proven to be linked to several and early cognitive decline, putting the trauma survivors at higher risk of developing dementia sooner than the general population. As an additional side effect of ill health and stress, studies have shown that ACEs cause biological impacts that accelerate biological aging, leading to shorter life expectancy than average. Non-biological outcomes of ACEs include higher than average likelihood of facing imprisonment, being unhoused, and these states tend to contribute to a person being more likely to face social isolation, suffer financial difficulties throughout their lives. As you can see, experiencing ACEs have lifelong impacts that are just beginning to be recognized as having the potential to cause an outsized effect on public health, and increasing costs and creating public burden. The concern about this heightened when viewing the expected boom in the older population that is expected to age by 2030. The older population is quickly exploding and can burden our healthcare system due to their higher need of care. Each additional ACE that a person experiences increases the risk of having multimorbidity factor by 12%. Therefore, a person who experienced one ACE is 12.9% more likely to have certain health conditions than average. But imagine a person who experienced 5 ACEs or more likely to have 60% adverse health conditions than average. The number only gets worse if they experience all the traumas listed on an ACE intake. Trauma survivors are more likely to die young, but have a greater level of frailty requiring a higher level of care earlier in life. Currently, healthcare providers rarely screen their patients for ACEs, leading to incomplete or standard care for this population. ACEs often go unreported and therefore untreated. Many people suffer trauma in childhood but don't report these experiences due to not trusting people, maybe not remembering, or maybe those memories have faded over time. There is no standard practice for gathering ACEs history in general, but these histories are less likely to be gathered for adults, as the general thought is that people will have overcome their traumas by adulthood. Many healthcare professionals do not understand the full impact of ACEs and do not have training on how to identify, address, or treat these patients' histories. This lack of information leads to fragmented, ineffective healthcare that only treats symptoms but not the root cause. The purpose of this project is trifold. To develop universal ACE intake form to take histories of the older adult, to create an educational toolkit for healthcare professionals to gain an understanding of ACEs, an intake form, and how the answers they receive may guide their care. 3, to create a greater degree of holistic care that goes into account to address trauma experience in early life and to reduce adverse outcomes in later stages of life. The target audience is healthcare professionals and patients. The content will include definitions, explain risk factors and potential outcomes, and give support for understanding evaluations. Printed materials and in-person training will be developed. The overall plan is to research, create content, develop the toolkit, test the toolkit, and distribute the results and training. Sorry, I didn't know if it changed. There are 2 materials to be created. The intake form, which will screen patients for ACEs based on established standard of care. The ACEs questionnaire used for young pediatric patients that is currently being used. A pamphlet to be provided to patients in the time the questionnaire is given, and it'll give them an explanation of why they're taking this and provide examples for them. This purpose of the workshop is to provide healthcare professionals and providers with an understanding of the importance of screening for ACEs. which should also enhance their buy-in and adapting to apply this practice. It will cover the intake form, how to use it, how to provide high level of guidance, and how these results may also inform better diagnosis and recommendations. Examples of ACEs and their long-term effects on people will be shared for the purpose of creating connections between the event, the impact of the event, and the potential outcome of these events. The expected outcome of this project are that it will result in establishing standard screening for ACEs, which should result in better diagnosis and improved holistic care. That the standard of care will shift to address the root cause and not just treating the symptoms. And applying the toolkit and increasing knowledge will create better support for healthier aging and reduce the burden on public and private healthcare systems. The project identifies that there is a gap in our current practice in which older adults are not screened for ACEs, which often negatively affect their mental, emotional, and physical health, meaning that there is no identification for root causes for chronic illness on any level. Implementing this toolkit for use in medical, social care, long-term care field as part of the standard practice helps these care providers to become familiar with ACEs, their effects, and how to assess them and what steps to take. Additionally, approaching this care creates a higher level of compassion among all types of caregivers, as it is a trauma-informed and more holistic guide. When utilizing this toolkit and implementing a standard practice of screening older adults for ACEs, the information gathered should be used to develop a more personalized care plan and take into account the effects of ACEs and the patient, client, resident. These care plans would be provided through consultation with all care partners, creating a united, more supportive plan of care, and would include wraparound services. Working with clarifying bodies and legislative bodies to implement a certification maintenance schedule would improve knowledge and improve the adoption of care based on identifying the ACEs and standard practice. In closing, because of the impact of ACEs hasn't been well understood until recently, this has created a public health emergency that has the potential to overwhelm our healthcare systems and the economy as a huge segment of our population reaches the age of 65. This has become less severe. This can become less severe if we implement this toolkit as a standard practice and raise awareness of lifelong impacts of ACEs. By implementing a standard practice to screen older adults for ACEs, we can create better health in our older population, bringing them greater quality of life and dignity, also while reducing the burden of financial care on our older population. And that is it.
All right. Really interesting because childhood trauma in older adults, I've been banging that drum forever, right? I think it's underrepresented, underreported, and not underrepresented, but we don't really look at it in terms of, how that can impact you over the course of the life. So thank you. Thank you for digging into that. Eve.
So I just have a quick question for Georgette, and it's okay if not, but I was just wondering if you have gathered any like research or specific resources on how to help older adults who have been through ACEs, who are also actively going through Alzheimer's or dementia, because I know that it can bring up those repressed childhood memories even more. So I was just seeing if what you've gathered on that.
So, I recently just got a job with the Council on Aging. And so I was given permission to go and talk to people that have cognitive health versus people that don't. And one of the things that I have done in my project is I made a form that has pictures. So people that have cognitive issues, instead of saying like maybe they don't understand the words, but if you were to say, was your parent ever incarcerated, you would see a picture of a person that has like somebody behind bars, or like maybe a picture of somebody like raising their fist, like if you were asking them about violence, and that they can point to that picture. So as far as like the research base, I haven't done that component yet. I am trying to figure out how to do that so I can implement that. So there is more research based on that. But as far as like when I did give the survey to the older population, one of the things that I did implement is that I changed the wording in the intake form because, say, for instance, um, maybe it talks about oral sex or anal sex, and maybe they're not comfortable with that. So I changed the language, or I added in factors of like war, or if you lost a spouse, or so I took the original ACEs and I based it and I changed the wording and I made it where it was more geared towards the older adult. And so I don't know if that answers your question.
No, it does. Thank you. Thank you. I really appreciate it. I hope to follow up with your research that you collect throughout your career.
Thank you.
Other questions, comments? Georgette, thank you and congratulations for your multi awards that you have won for your project. So
Thank you.
it's nice to see work with older adults getting some awards and on the educational front. So nice work. Okay, so we have last but not least from Pauline DeLong and Elizabeth Bogomil, both of your last names I probably did not say right, but Advancing Rural Aging Policy in California, Research Insights on Healthcare, Long-Term Services, Supports, and Housing. As somebody that comes from very rural Northern California, I am very excited to hear your presentation. So take it away.
Thank you so much, Donna. So my name is Elizabeth Bogomil. I'm a PhD in sociology, and I'm currently working with the Inland Coalition on Aging. Shout out to Ben, who is our chair here. And Pauline DeLang Martinez is also a PhD, and she is working with the Family Caregiving Institute at the Betty Irene Moore School of Nursing at UC Davis. And so this was a statewide project on advancing rural aging policy in California, research insights on healthcare, housing, and long-term services and supports. So a brief overview. We're going to start with the background and methods, and then we'll cover key findings on housing, long-term services and supports, healthcare, and then resources. And we'll close out with a brief question and answer if we have time. So why action is needed now? While California is often seen as urban, it's actually largely rural. 57 of its 58 counties include rural areas. Nearly 1 in 11 Californians aged 65 and older live in a rural community. In those areas, older adults make up a full quarter of the population, compared with 1 in 6 statewide. And over 40% of older adults in rural areas are living with a disability. So looking ahead, the needs of older adults in rural areas will grow quickly. By 2040, rural population aged 85 and older is projected to increase by 158%, nearly 50 times faster than the working age population. This shift will put significant strain on the already limited rural health and support system.
Great. So to provide a little background on our research project, our research really came out of California's Master Plan for Aging. Launched in 2021, the Master Plan provides a 10-year blueprint to promote healthy aging and support quality of life for older adults, individuals with disabilities, and their family caregivers. And the plan is organized around the 5 goals listed on the slide here, including housing, health, inclusion and equity, caregiving, and affordability. However, when the plan first launched in 2021, there was some critiques and concerns that the unique needs of rural older adults were not reflected within the plan. To address this gap, the California Department of Aging reached out to their philanthropic partners for help, and the SCAN Foundation, a public charity, invested in the Rural MPA Initiative. MPA is short for Master Plan for Aging. And they funded 3 coalitions over 2 years to develop local multi-sector plans for aging, and I served as the lead consultant. For this project, we focused our effort on 7 counties. In the North State, we focused in on Shasta, Butte, and Glen. In the Central Valley, we focused on Kings and Tulare counties, and the Inland Empire focused on Riverside and San Bernardino counties. And the first step in each region was to establish a multi-sector advisory committee, including local government, healthcare, aging and disability service providers, and they embarked on conducting a very thorough local needs assessment. They began by compiling existing data from a variety of sources, as well as gathered new data through focus groups and interviews with a total of 227 providers, caregivers, and diverse older adults, with a focus on elevating underrepresented voices. Each of the regions developed locally tailored interview guides, digging into challenges and opportunities related to housing, transportation, food access, behavioral health, caregiving, and healthcare. The feedback informed a series of local action plans with recommendations for policy and programs at the regional and county levels. And you're welcome to access them at the links on the slide here. In 2025, our project shifted from local planning to state level policy solutions. Building upon our qualitative research from the Rural MPA Initiative, we interviewed 60 additional policy experts to identify opportunities at the state level to advance rural equity and aging. And last November, we launched a series of policy briefs focusing on long-term services and supports, healthcare, and housing instability. These policy briefs are designed for policymakers, state agencies, and advocates, and are the first policy briefs focused on rural aging in California that have been published since 2011. Today, Elizabeth and I will briefly highlight some of our key findings and recommendations, but I really encourage you to look at the full briefs because we only have 12 minutes, so there's only so much we can cover.
So in rural California, housing challenges for older adults exist along a broad spectrum, from those at risk of losing housing to those living in unsafe and inadequate conditions. Economic insecurity is a major driver. Many older adults live on fixed incomes that don't keep pace with the rising cost of housing and utilities. At the same time, accessing housing assistance is difficult with long wait lists, complex applications, and limited local services. Even when housing is secured, it's often substandard or not designed for aging, lacking basic repairs, accessibility features, safety modifications. Geographic isolation compounds these issues as well, making it harder to access services, contractors, or support networks. And for many communities, natural disasters like wildfires have had a lasting impact, destroying housing stock, driving up cost, and displacing older residents in long-term living environments. Together, these factors create a fragile and often overlooked housing landscape for rural Californians. So addressing housing needs for older adults in rural California requires targeted, coordinated action. These include expanding and preserving affordable housing that's designed for aging and investing in service-enriched housing models that connect residents to care and support. More resources are also needed for home repairs and accessibility modifications so older adults can remain safely in their homes. Strengthening housing navigation, eviction prevention, and cross-sector coordination can help people access and retain housing. And at the same time, improving how we measure homelessness and housing instability will better guide the solutions. And with growing climate risks, supporting disaster resilience and long-term recovery is essential to protecting housing stability.
So we learned that rural caregivers are older. They're more likely to be providing 40 or more hours of care each week, and they're less likely to receive paid or unpaid support. Many home and community-based services don't exist in rural areas, or they exist in very limited capacity. Things like MSSP, adult day programs, assisted living waivers, or CBAS programs. The direct care workforce shortages are more pronounced in rural regions. And additionally, many home care or home health agencies offer limited services in rural communities due to higher travel costs. There's also less IHSS providers available per consumer in rural California. And in general, rural older adults and family caregivers are more isolated than their urban or suburban counterparts. Beyond the travel costs, the direct care workers also experience low wages, high turnover, fragmented work environments, a lack of benefits, limited training and career mobility, high emotional and physical demands, and structural barriers, such as being allocated insufficient hours to care for individuals that require increasingly complex care. And while these challenges are not necessarily unique to rural areas, they're compounded by uniquely rural issues, such as the demographic trends of more older adults over 85, the long geographic distances, and climate-related impacts. Our policy briefs outline several recommendations, such as to expand caregiver respite, education, and counseling, increase navigation and case management, secure sustainable financing for a statewide long-term care benefit, strengthen and stabilize the direct care workforce, and create a statewide direct care workforce registry that could help caregivers find jobs, as well as to help long-term care facilities and families to find caregivers that have been vetted and trained. And finally, our policy briefs dig into healthcare challenges in rural California. Rural older Californians have a higher prevalence of chronic conditions such as heart disease, stroke, and lung disease, and this coincides with massive health workforce shortages. Many older adults we spoke to reported needing to book their primary or specialty care up to 6 months in advance, and they also described traveling really long distances to access care, with one visit taking either an entire day or even multiple days, requiring complex planning for transportation. These were massive stressors that led to people delaying or foregoing their healthcare altogether. Care coordination was another huge challenge, particularly hospital discharge, and there were persistent racial and ethnic inequities in access to care, including cultural and language barriers. All of this is occurring as rural hospitals and clinics are struggling to keep their doors open. And furthermore, the implementation of HR 1 will exacerbate the financial challenges of rural healthcare providers, with a predicted $137 billion in Medicaid cuts nationally in rural areas over the next decade. So some of our policy recommendations for healthcare included strengthening the rural healthcare workforce and expanding geriatric and dementia-capable care, simplifying navigation and strengthening care transitions, funding flexible transportation, for example, so people can get a ride from a friend or neighbor and be reimbursed for their gas and mileage, expanding telehealth, digital access, and mobile care delivery, and increasing community-based education and health literacy.
So based on the data that we've shared, we hope you have a better understanding of the challenges of aging in rural California. These challenges are interconnected. Social and geographic isolation limit daily support and connection, while transportation barriers make it difficult to reach care, services, and even basic needs like groceries. At the same time, there are persistent shortages in healthcare, behavioral health, and long-term services and supports. Even when these services exist, navigation and awareness barriers prevent many from accessing them. Food insecurity adds another layer of risk, especially for those on fixed incomes. And all of this is compounded by greater vulnerability to climate-related disasters, which can disrupt fragile support systems and housing stability. So our next slide will have a little bit of resources that are available to you to access.
Great. So there's the link to our policy brief series that we mentioned where we go into a lot more detail than we could go into today. We also, in our project, developed a toolkit for rural leaders and other communities that want to develop local master plans for aging. And then we thought we'd share again the links to the local plans in case you're interested in those particular regions. And some of the regions have already updated their plans and they're continuing to meet in action teams to guide implementation. So thanks so much, and we'd like to open it up for questions.
That was amazing. That was, as I mentioned earlier, I'm from a very rural area and have done a lot of my work on that. And it's there's such a forgotten population. And some of that is just, there's the principles of self-sustainability, right? But then you have to be self-sustaining if there's no transportation. And so I love that through the MPA that these things are kind of being brought more to light. So questions from anybody, comments?
I see a question in the chat about telehealth and what current challenges are being encountered. So there's challenges both on the provider side as well as the patient side. So from the provider side, many of these rural health clinics are smaller and they just are adopting EHRs for the first time. And so the technology really needs to evolve and they need more technical support and assistance. And also there's broadband challenges, not having good bandwidth. And from the patient side, beyond the broadband challenges, there's the digital literacy divide of not feeling comfortable with technology, which is exacerbated for those with limited English proficiency or other disabilities like visual or hearing challenges. So a lot of different challenges with telehealth. It's not really the solution to all the gaps in healthcare, but it is one of many solutions and it needs to be implemented thoughtfully. And some of the expansions during COVID were helpful, like allowing the patient to be at home instead of having it only be from clinic to clinic. So we're hopeful that those types of exemptions will continue. And one thing I didn't have time to mention in the presentation is there's also along with HR1, which implemented massive Medicaid cuts, there was a rural health transformation program that was implemented, which is an investment of $50 billion nationally to invest in rural health. So in California, we'll have about $1 billion from 2026 to 2030 and part of that funding will invest in improving telehealth and electronic health records and just the technical capacity of rural healthcare providers.
Something worth considering when we think about telehealth, we need access to either the internet or phone reception to make that happen. And there's whole swaths of Riverside and San Bernardino counties. San Bernardino is the biggest county in the continental United States. There's whole swaths that just don't have reliable phone access. Even if you're on a cell phone, you're either it's fuzzy, it goes in and out. So that is something that has to be considered, even if it is there, whether or not the recipient can access it.
I see Anna Lee has her hand up.
Yes, sorry, I didn't want to type again. You mentioned that this digital illiteracy going on within the rural community. Do you know if there are any community centers or senior centers that teach digital literacy classes?
Yeah, one of the best resources is the local library. And there's been statewide initiatives going through libraries to advance digital literacy. And there was a lot of funding after COVID that invested in that. And I think some of that has kind of ended. So would like to see more of that because it is a continued challenge.
And that presumes that people are able to, one, get to the local library or senior center, and two, that they have one near them. And at least in our regions, yeah,
sorry.
Our regions, we have that problem. There is senior center, but some individuals require bus transport. So they have to decide between getting lunch at the senior center 2 days a week or finding one of those days to get groceries. So there's hard choices that are being made.
Yeah, that was going to be my follow-up. The problem might still be a transportation issue to get to these resources.
Definitely.
And there, at least when I was doing some work about 15 years ago, doing some research on this issue, there were still areas in California that did not have access to any internet, right? No Wi-Fi, no broadband. I think, Elizabeth, that's kind of what you were saying. It's like fuzzy, but some have none. And with it seems like the entire world being, technologically and electronically connected, there really is some disparity there that's problematic. So yeah, thank you for kind of highlighting and shining light on that. Any other thoughts, questions? Okay, so the bill regarding telehealth carrier of last resort is under threat of elimination in California. Wow. Yeah. So we got some work to do for our rural folks. Thank you for championing that. Okay, so it's time. Now we're moving on to drum roll. We are going to, I'm going to put up the poll here for the best in showcase. And so please vote for one of the 6 that you would like to receive best in showcase. So the poll, is everybody seeing the poll there?
Yes.
All right, so make your vote and then we'll see who our winner is here. We got a couple of tight races, so if you haven't voted, vote. Oh, I don't know, Alex, are you not, you didn't see the poll?
Oh no, sorry. I was just joking that they're all so good.
Oh, how do we choose? Yeah.
Yeah.
It's a little bit of Sophie's choice for sure. So, all right, 5
Oh,
seconds.
Natasha
Oh.
doesn't see the poll.
Yeah, I only see track 2, so I don't know how track 1 votes.
Oh, track 1 votes in track 1.
Oh, we were supposed to vote back there.
Yeah. Well, I don't know if I can, let me see what happens when I bring up the other poll too. Okay, I know who wins here, so let me see if I can bring up the other poll for those that may want to. Yeah, I don't have the option.
Is
So
Amiko here?
I think
I'm here. What's
Oh,
the
okay.
We
Amiko,
didn't,
did
I
you
guess we
guys
were
already
supposed to
vote?
vote. We were supposed to vote back in our room and we did not.
Yeah, so I wasn't able to do the polling, but I can do the poll now. Do you want me to?
Okay, well, I'm going to close out track 2. So if anybody has any last minute votes for track 2. Okay, I'm going to end this poll
Okay,
and you can go.
track 1. I'm gonna launch it right now. So, okay, it's on. So you can do, you can pick one of your favorite if you were in that.
So while that's happening, I just want to just communicate with everybody just a lot of gratitude and appreciation for you sharing the presenters, sharing your work, not only doing the work, but also sharing it with us. This is kind of meant as a little kind of blip and a little insight to what's happening. And I just appreciate you letting us know the type of work that's happening. And so we can further follow up and connect. And for those of you that are, in the mid stages of doing your research, please come back and share your outcomes because it's really interesting and important. So CCGG, thanks you very much for your time and participation. So I'm gonna, go ahead, Amiko.
Yeah, I think the poll, I think it's already kind of quieted it down. So the winner for
Okay.
track 1 is
Track 1 winner.
Lost Our Link by Tara and Steve. Congratulations.
Thank you so much. What an honor.
Yeah.
Yay. And the winner for track 2, drum roll, is Emerson with Centering LGBTQ plus aging experience and creating a trauma-informed, gender-affirming, HIV-sensitive caregiver training. So Emerson, fantastic work. So CCGG will be in touch with you to get you your prize. We do this research showcase both in spring semester and fall semester, so keep your eyes open. It'll be probably in November sometime in the fall. We haven't picked that date yet. We try to work around major conferences and holidays and such like that. So we hope that this has been fulfilling for you and look forward to you joining us in the future, either as a participant, presenter, or an attendee. Any final words, Amiko or Mary?
No, I think it's been really wonderful that, a lot of people with different backgrounds, come together and then share, their work. So I really appreciate, their time. I know it's Tuesday in the middle of the day, and it's hard to, you know, uh, s- carve out, this time, for this presentation. So I appreciate it.
Yeah, I'll just add, I put this in the other group, but just that it's always really like makes my heart full to hear all of the things that people are doing in the community to improve the lives of older adults. Like just to hear all this good news is just really, really, really nice. So I appreciate you all taking your time to kind of help us remember what we're doing and how important it is. And also, I put a lot of links in the chat. So there's the Facebook, the Instagram, and our website if you're interested in connecting with us or seeing when our recordings go live. And our next event, like I said, we're working on a policy thing as well as some other things.
Fantastic. So the links should be up. The recording should be up by next week. And so keep an eye on the CCGG website. Any other final thoughts from anybody? All right. Well, go older adults, go gerontology. Take care. Have a wonderful day, everybody. And we're going to keep the room open if anybody wants to share and network and hang out. So that'll be open for you if you want to kick around with us. I am going to stop the record, so